Hi, I'd like to welcome everybody to the next in our series of UOA On Demand. Today, we're going to talk about issues regarding carpal tunnel. My name is Tim Leddy. I'm an orthopedic surgeon with specialty training in hand and upper extremity. I did my fellowship training for that at the Mayo Clinic. Joining me today is Dr. Christopher Doumas, also an expert in hand and upper extremity, having trained at Penn. Ryan Coyle is with us as well. He did his hand and upper extremity training at NYU. So today we're going to have a discussion related to carpal tunnel syndrome, the symptoms, the progression, the treatment options, and also touching on differential diagnoses. So with that, we're going to start with Dr. Coyle. Young man, why don't you tell us how you would describe carpal tunnel syndrome to one of your patients?
Well, I would describe carpal tunnel syndrome as essentially it's a problem where a nerve gets trapped in a space called the carpal tunnel. So we call it a syndrome because it's sort of a constellation of symptoms and physical findings that the doctor might elicit. But the most common complaints that people come in with are numbness and pain, and sometimes difficulty picking up objects, complaining of weakness in the hands, and every once in a while complaining quite frequently complaining of pain. But there's not one single thing that everybody will always present with. So essentially though, it's a nerve being stuck in a space with not enough space for the nerve.
What would you say would be the top three complaints that people have coming in with carpal tunnel type symptoms?
Probably number one is numbness, and number two is pain, especially at night. And then weakness and or difficulty with fine grasp and fine motor function in the hands.
Dr. Doumas, how would you initially treat somebody with those types of symptoms coming into the office?
Most of the time, dependent on the progression of what their symptoms are. We like to start conservatively, obviously. Simply a wrist brace is the most common thing that I give people in their first visit or telemedicine visit, depending on what we're doing and what time things are going on. So basically a wrist brace in about neutral position where the wrist is flat. Most of the ones over the counter are a little bit 20 degrees, 30 degrees in wrist extension, which still does put some pressure across the nerve. So usually having it flat where the back of the hand is even with the forearm is usually the best thing to do. I usually have them take a little bit of a bend out of the metal to try and keep it in a more neutral position. Simply sleeping in that at night is very beneficial, and most patients find good relief from that. Also, anti-inflammatories can occasionally be helpful as well. So I put them on a 1 to 2 week course of that to try to help reduce any inflammation or swelling. If there's very frequently tendinitis associated with the carpal tunnel, since those tendons do go through that tunnel with the nerve, it helps to reduce any of that inflammation and take some of the pressure off the nerve. So those are my really main initial steps for treatment and from a conservative standpoint. If things progress or if they've been around for much longer, I'll sometimes also offer an injection depending on how long they've had symptoms for or how severe they are at the time.
Dr. Coyle, when would you suggest doing a more advanced study for diagnosing carpal tunnel syndrome?
So we know that more advanced studies, ultrasound, MRI, and EMG nerve conduction studies are not always necessary for the diagnosis. And if somebody comes in with all of the physical findings and the symptoms that all match up with a diagnosis of carpal tunnel syndrome, I don't always order the tests. But if the patient has complaints of radiating pain, especially if they have neck pain or a history of cervical spine problems, or say if they say all their fingers are numb and tingly, then I think that sometimes before you recommend doing any sort of especially any surgery, but if you just in order to get a diagnosis, the advanced studies can be helpful because you don't want to miss any other diagnoses that could cause the patient's symptoms.
And the use of ultrasound is, by all means, it's not new, but in the diagnosis and treatment of carpal tunnel syndrome, we've been using it more and more. How do you diagnose carpal tunnel syndrome with an ultrasound?
Well, there are different criteria, such as looking at the space available for the nerve, the space that the nerve occupies compared to the space of the carpal tunnel that you can see in ultrasound. I don't frequently use it in my practice, just because that wasn't what I was taught to do in training. I do know that people use it, but at the end of the day, it's a clinical diagnosis, and the physical. It's not always a perfectly easy diagnosis to make on clinical exam, but at the end of the day, the patient's symptoms and the manifestations guide the treatment and how long the symptoms been going on for and the severity of them. So I don't frequently use it, but it is used out there.
You use carpal tunnel injections also to help differentiate those folks that have compression at the nerve versus other locations? Excuse me, compression at the wrist.
I think it can be very helpful, and I definitely will recommend injections if there is especially if it's an acute onset of symptoms, or if there's a reversible cause of the compression, such as a patient who's pregnant and has swollen extremities, and this is a condition that we expect to go, to be somewhat reversible in the future. And if it's a patient that's had symptoms that are slowly progressive for 10 years, I'm not going to push them to an injection just because I don't feel like it's necessarily a reversible underlying cause of the problem.
Dr. Doumas, if somebody has symptoms that are very much corollary with having carpal tunnel syndrome, but it's not perfect, and your tests, including whether it's EMG or a trial of a steroid injection, are not successful for you, what are the different types of things do you think about that may be actually causing those symptoms?
Sure. So, one of the reasons, just to echo some of the further comments, the previous comments of Dr. Coyle, is I don't routinely use ultrasound in my practice for a diagnostic purpose as well either. And I reserve getting the nerve studies if we're thinking about some further intervention, typically, because why go through the test once now and once a year or two from now, depending on when you're going to treat it. So I usually use the algorithm as when it's going to change your management. That's the reason to get a study. I use the ultrasound in my practice more for guided injections to the carpal tunnel, because I do think it makes sure that especially for the case that you're talking about right now, when there's a question mark, is it more proximal compression in the forearm? Is it more proximal compression in the neck or in the thoracic outlet? When you're looking at thoracic outlet syndrome, it helps to differentiate some of those other diagnoses and weed them out, sort of say. So, I use the ultrasound to make sure that I know I'm in the carpal tunnel, because you can visualize the needle in the carpal tunnel under an ultrasound for a guided injection to be certain you have it there. Because if there is good relief from that, then you've got a pretty good chance that the surgery is going to work, or that is the diagnosis. If it doesn't work, then I start to question it much further for sure. And I start to look higher up, whether it's proximal in the forearm, whether it's something along the lines of thoracic outlet syndrome, which is compression up of the vessels up in the neck area and the above the clavicle, or whether it's from the cervical spine.
Dr. Coyle, what are some of the breaking points for you when you start to think, well, maybe conservative management has been tapped out and it's time to start to consider something more invasive?
Well, number one, it always boils down to what the patient wants out of the treatment. Carpal tunnel syndrome is a problem, and it can be debilitating if it's bad. But it boils down to how long it's been bothering them, how bad the symptoms are, and what they want to do. One of the findings that I really don't push people towards conservative management and push them towards thinking about surgery is the presence of weakness in the hand, or an obvious atrophy of the muscles that the nerve innervates in the palm. That's a sign of really progressive and irreversible nerve damage. And the goal at the end of the day is to make the patient feel better. Those changes may not be reversible, but if you know that the problem has been around for quite a while, the chances of meaningfully impacting their life with your treatment, short of surgery, is not great, I think.
I agree with that. And I think that, I always explain to my patients that there are certain red flags that say, listen, I know you don't want surgery, but this is when you need to kind of pull the trigger and operate on this. Is, constant symptoms. I think you're starting to teeter that line of going over to permanent nerve problems versus reversible. Weakness in the hand when you test the thenar muscles and through here when these start getting weak, or if you're seeing visible atrophy, or if you're seeing any nerve changes in the muscle on the nerve conduction study on the EMG component of that. To me, those are my red flags that say that, listen, you need surgery unless there's some reason stopping you from doing it. So I don't know what your experience has been, Tim.
Well, before I answer that, I want to know what kind of reasons would you use to not do surgery? Reasons that you mentioned to stop it. At what point would you say maybe we're going too fast, too far?
Well, in those cases, I don't think there's much of a reason to stop you from doing it. And especially at this stage of the game, things have changed a lot since I first started my practice. I used to do these under, sedation with local anesthesia. And now we've turned to some of these newer techniques where we use WALANT, which is WALANT, or wide awake local anesthesia, no tourniquet. And, even older, sicker patients that I previously wouldn't have booked for surgery, even thought about it, because it's not worth the risks of even the sedation, we can do now quite comfortably under local. So there's very few patients that I would say are contraindicated now for an operation for this. So, and it gives a lot of quality of life for somebody in their 80s and even their 90s who have really bad carpal tunnel. You can still get dramatic relief even when they've had compression going on for years. It may take longer for it to come back and for that nerve to wake up, but it does come back to some extent.
So to answer your question, I mean, I'll echo many of the things that you guys have already said. I agree with pretty much all of that. I like to break the carpal tunnel syndrome into basically three different things for patients. One would be the painful pins and needles that they can have, particularly at nighttime, that shaking out of the hand that they have to do, or dangling the hand off the end of the bed to get it to wake up. Then there's a numbness, and it's very important, I think, to differentiate the numbness from the pins and needles. They're not the same thing. And of course, you both referenced the weakness of the thumb muscle, which can be, irreparable if you let that go too far. I do like to spend a little time talking to patients about the weakness in the thumb muscle, because that's sort of a big ticket item for me. I think as much as it's important for us to find a way to make patients comfortable, I think we also need to protect from permanent damage, and that's where that lives. To be able to explain to somebody the difference between apposition or key pinch and opposition or pinching between the fingertips, in many cases opens their eyes to saying, oh, that's why I can't push my button through the hole anymore. And those are the kinds of things that I want to try and preserve in those patients. So again, barring some sort of significant comorbidity, I think those patients by and large can benefit, if not from all three of those things, from at least two of those things. In many cases, even if you can't get the thumb muscle to come back, you can relieve their symptoms of dysesthesias or the painful pins and needles. And over time, they can improve their sensation pretty much in all cases, with rare exceptions. Those exceptions would be that those folks that have a pre-existing problem with their nerve already, peripheral nerve issues regarding or related to diabetes, or, we use the fancy term of idiopathic, which just means we don't know why it came around. So comments about that, either one of you?
Well, I always tell people that the goal of the surgery is to try to keep things from getting worse. And like Chris mentioned, I hardly ever will, tell somebody that they're too sick for this surgery. There's risks to every treatment we do. And the real risk to conservative treatment is that the patient's not going to get better. You're not going to work. You're wasting the patient's time. And the patients are coming to us asking for help. So I think it's our goal to try to find the treatment that's going to help them with exposing them to the least risk. And this, quite frankly, is one of the least risky procedures that we do. I always tell people that patients that, there are big surgeries and there are smaller surgeries with less risk. And this is one of the, like Chris mentioned, doing this wide awake with local anesthesia is perfectly safe. It's effective. You don't really even need to use the tourniquet. It's essentially, it's essentially something that some doctors do it in the office. I don't routinely do it in the office. It is feasible to do it. And it's that type of procedure that can really impact a patient's life. A lot of people don't want surgery, but at the end of the day, it's one of the least risky things that we do in hand surgery.
So I think, because of the access that we have to a surgery center, we've in our practice have elected to do those procedures in an operating room. And I think that's always the safest way to do it. Just a quick around the horn now. Chris, you've already mentioned that you like to use the Wallance surgery. I myself do majority of these with patients wide awake, straight local anesthetic, but I do use a tourniquet for the beginning part of the procedure. It usually ends up being 4 or 5 minutes, which is not too terrible for folks. I do the majority of mine open, but I will do them endoscopically in the appropriately selected patient. And I want to know from you guys, well, first of all, Ryan, you use a similar kind of techniques in terms of anesthesia, and what are your feelings about open versus endoscopic?
I let the patient decide whether they want to do sedation versus wide awake. There's certain other procedures like a trigger finger release where I feel strongly about having the patient be awake and being able to confirm mechanically that the problem is gone. With this type of surgery, for various reasons, you don't really need to have the patient participate. So it's up to the patient in terms of what they prefer. Some people don't want to be sedated. Some people don't want to experience the surgery. It doesn't really affect technically, doing the procedure either way. In terms of open versus endoscopic, there's a lot of different reasons in the literature and personal experience of the people that I trained with regarding personal thoughts and feelings about doing the surgery open versus endoscopic. There is good literature to support that there's a slightly quicker return to activity, return to work with endoscopic surgery. And there is literature to support that there's a higher risk of nerve injury, which can be problematic, although very low, certainly possibly more prevalent with endoscopic surgery. So realistically, like you, I can offer it in the properly selected patient, but by and large, most of my patients choose to do it open, and the results are good.
So I'll echo those comments as well. I tend to do mine through what's called a mini open incision. You can do this really through a 1.5 to 2 centimeter incision. And I explain it to them in the way that, that you never know if their other side had been done somewhere else and they have a much bigger incision, if it was done years earlier, or if their mother or father, brother or sister had one done earlier on in time, there may be a much bigger incision. But you can do this through a pretty small incision and see everything with the retractors and the techniques that we have nowadays. I find it's important to make sure that you can see that the entire ligament is released proximally and distally, meaning further towards the fingers as well as towards the wrist, so that you're completely released. And I think you can see that much better through an open procedure where I know I can spread it open and directly visualize that. There are some small fascial bands that can sometimes be present through endoscopic techniques. And there is about a 5% documented incidence of needing to redo it open or having incomplete release of the ligament. And when you explain that to patients, I kind of tell them in the office, I'm happy to do it either direction as well, endoscopic or open. When you tell them there's about a 1 in 20 chance, and I do a lot of carpal tunnels over the course of my career, that's a lot of people that might need to have it redone because it was incompletely released. And that's just based on the literature standards. So once you tell them that, it seems more common to them. And I think most people then say, just open it and just be done with it so that we know we're done. Because you don't ever want to go back in on somebody. And that's when you kind of shoot them straight like that and explain it to them in detail. I think patients really gravitate more towards the small open procedure.
The variable anatomy of the nerves and structures in the carpal tunnel can be actually quite impressive. This past week, we actually had somebody with a palmaris profundus, which is an unusual orientation of the tendon deep to the carpal ligament. And you would not necessarily be able to identify that done endoscopically and leave one of those areas of secondary compression behind. And you're right, nobody likes to do the job twice. If you can avoid that by doing a more thorough procedure, I think that's the case. I would also add one other thing. It's rare but occasional with those revision surgeries that you need to have a bigger exposure. And on purpose, we'll make a bigger incision in those cases just to make sure that there's no stone left unturned. I want to move on to what you tell your folks and your patients regarding the postoperative recovery. Let's start with Dr. Coyle.
So I routinely see patients back for one visit and sometimes more if they're having any issues, persistent pain. I tell them to expect at least 6 weeks to 2 months of pain in the palm, whether with endoscopic or open surgery. Essentially, you're making a deep cut into the palm to unroof the ligament, to cut the ligament and allow the nerve to breathe. So it's essentially a deep controlled laceration. And people have soreness and discomfort in the palm, especially when they're getting up from a chair, or pressing on an object with the palm. And we use our palms for a lot in terms of heavy lifting and pressure. So people are not uncommonly, they experience this sort of discomfort. And it's important to tell them beforehand to expect it so they're not bothered, they don't think anything's wrong. In general, once the skin is healed, I'll let the patient kind of do whatever they want to tolerance. I tell them, you don't need a cast. That's up to surgeon preference, but we do know that casting doesn't really have any sort of benefit to the patient, and that a soft bandage is sufficient just for padding to allow the skin to heal. And once the skin is healed, the patient can kind of do whatever they want. Although they don't, they will have some discomfort, and that's just to be expected. And then in terms of nerve recovery, that's very variable. But I tell people the longer you've had compression, the longer you've had symptoms, the longer they'll take to go away. And the pain is typically what goes away first, followed by the numbness, and then the weakness may improve later on, but that doesn't always fully go away.
Dr. Doumas, what do you tell your folks? Anything different?
I think pain control is also an issue for some of these patients sometimes, because the good news is nowadays, we have other modalities where we're not just, throwing narcotics at patients these days. There's a lot bigger issue that we're worried about in the community at this point. So, typically you don't need narcotics for this type of a surgery as well. My typical regimen is just Aleve twice daily with breakfast and dinner, as long as you're allowed to take it medically. And there's no contraindications to that, as well as Tylenol in between. And that's usually more than enough for I would say 99% of patients that I've been treating this way for years. So it would be absolutely rare for somebody to request or need a narcotic for this. I think that's one of the biggest benefits of this is you don't have to be worried about that going forward. I do basically keep my people bandaged up for about 9-10 days, at least a week, because I do like to have them in a sterile bandage for that amount of time. I think it's excellent for healing. I do pad them well, mainly to protect them from themselves, because I've had patients basically working on their pons 3 days after surgery, putting their hand in the water on a rock with pressure. And I like to have it nice and dry in there as long as possible. So I try to protect people from themselves because, it's not a very painful surgery. So people try to get back. My goal is to get people back as fast as possible. And I like them to use their hands as quickly and intelligently as possible. So now, do I have you hammering afterwards? No, but you can have secretaries and people who type for a living and go back to work very quickly, 2 to 3 days after from the surgery in most cases. Again, some of these do have some discomfort. I do caution them as well. You can have pillar pain in 25 to 30% of patients, whether it's done open or endoscopic. And that's basically tenderness in the palm around the scar from the ligament. And there's not a whole lot you can do about that. Some people do require some therapy even every now and then for this, but most people don't require to get into occupational therapy or a hand therapist. But that can be helpful if you are suffering from what's called pillar pain. And so I do find that useful. I do mention that to everybody so that they are aware of that. Again, this could be a little bit uncomfortable for about 2 months as well in some patients. But the majority of patients, 2 weeks out, once the skin is healed, are really moving quite well and having no issues at that time, just a small amount of soreness with direct pressure. So,
Dr. Coyle, do you find yourself using much hand therapy after this procedure?
I really don't. Like Dr. Doumas mentioned, I tell patients you will have pain. Don't worry about it. Narcotics are not necessary. And if you counsel people appropriately, like they really are not worried by the pain. It's more soreness. To answer your question, I definitely don't use hand therapy routinely in either trigger finger or carpal tunnel surgery. I feel people don't need it. If they're counseled that the soreness is okay and the more they use their hand, the more their function will come back. I find there's hardly ever any issues long-term with difficulty with finger motion, unless there are any significant adhesions in the carpal tunnel between the flexor tendons, which is pretty rare. Those can be treated at the time of surgery, and the patients usually are not, they don't have any difficulty with finger motion, greater than a couple days out.
I find it to be the rare patient that either required a synovectomy, which is removing some of that extra tissue in the carpal canal, or patients that have a sort of an abnormal response, significant swelling, and therefore stiffness in the hand. They need to have hand therapy, but by and large, it's a pretty rare need for that post-operatively. Chris, you paint a pretty rosy picture about people going back to work 2 or 3 days later, and certainly that can be the case with the right selected patient and the right occupation. But there are some people that do heavier duty jobs. How often do you find that they're a little bit slower to go, and how long before they're back to work in a heavier job?
for sure. And I think a lot of it depends on more the tendons that may be associated with it. Very frequently, as I mentioned earlier, the tendons can be associated with carpal tunnel when you have a lot of tenosynovitis or inflammatory tissue around those tendons, whether it be at the wrist or in the hand at the palm, even without locking like a trigger finger, which are also commonly associated with carpal tunnel. Sometimes people just have pain, and I always make sure I check those tendons pre-op before the surgery to make sure that they're not inflamed, causing any locking, because sometimes the patient doesn't feel it, but they experience it, and you can actually feel it on the examination in the office. So, I try to make sure you don't miss those, number one. If they are people that have tendonitis associated with their carpal tunnel, they definitely take a little bit longer, I say, to rehab and to get back to things. Definitely more manual labor will take a little bit longer to get back to things. And it can be anywhere from 3 to 4 weeks. It could be up to 6 to 8 weeks, depending on the amount of scarring and pillar pain or scar tenderness that you get. So, one of the things that's important we didn't mention as well is some of the scar management post-op with silicone pads and, scar massage, where you're basically just using your other hand. And again, you don't need a therapist to necessarily do it, but you got to do it yourself, and you've got to be diligent about it, because you got to try and help break up some of those adhesions in the skin. And it works much quicker that way to get you feeling more comfortable.
Staying on the same theme with therapy, only do either one of you put much faith in, other treatments such as things like hand therapy prior to surgery, or acupuncture, or laser therapy, or any of the other potential alternative treatments for management?
I think that, again, it boils down to kind of how long the symptoms have been there before. There are, hand therapy treatments, nerve glides, there's definitely a lot of literature about non-surgical but invasive methods of treating the carpal tunnel, like ultrasound guided hydrodissection and certainly ultrasound guided injections that non-surgeons might do, and those are all reasonable to try if the patient really wants to avoid surgery early on. But certainly the longer that the symptoms have been there, especially if there's no underlying cause, if it's truly what we call idiopathic carpal tunnel syndrome, I counsel the patients that they can try whatever they want, but I don't expect that it's going to help them.
we're using some language now that some people might not understand. What do you mean by hydrodissection, and what do you mean by nerve glides?
Well, nerve glides are essentially, and I know that our in my fellowship, we would refer people to hand therapists to work on basically nerve gliding, working on with range of motion, trying to get your tendons and nerves to kind of glide more frequently, so glide easier, so they won't get stuck and adhese as easily. Hydrodissection is a technique where under ultrasound, you basically try to break up adhesions around a nerve that may be binding the nerve up in the tunnel, and do that by injecting fluid under ultrasound guidance near the nerve. There is literature to support it. I don't routinely recommend people to go to try it, but it is an option.
And Chris, why don't you take a swing at laser therapy, and or any other treatments that you've heard about regarding carpal tunnel?
Sure, and I would agree and echo some of those statements as well. Is to a point, I don't think it's worth doing a lot of those. We teach nerve glides all the time in the office ourselves, and I can comfortably teach a patient to do that, give them handouts for it as well, which we have in our offices and available to them. They could probably find them online as well. So when they get to us, when they're at that standpoint, they probably don't need that. Most patients are probably far beyond that, unfortunately, where it's going to help maybe some of those mild cases. As far as some of those other, laser treatments and things of that nature, and the hydrodissection that you talked about injecting the fluid, again, there are risks to everything. And I think that's one of the comments that I'd like to make about that is, depending on where you're going and who's doing it, you've got to obviously buyer beware. You need to be very, very careful, because they could have significant complications from some of those things where you can actually cause further damage to the nerve. Now, one of the important things from a treatment standpoint, I would cover with all of those is, our treatment when we treat carpal tunnel syndrome is basically releasing that ligament. We cut the ligament where that nerve is entrapped with the tendons, and we spread it open. We open up the canal. Some of those things are looking to more dilated things of that nature. When we do our surgery, we don't actually really go after dissecting the nerve out and the branches out. We don't dissect all the tendons out. And it's actually been proven that you don't want to do those types of things. And it's against the American Society for Surgery, the hand guidelines going and doing those things. So anything that you're doing further realistically with the nerve or with those tendons, I think is overkill and could be detrimental. So I don't recommend it.
Another question, now you've got somebody through the surgery, you've got them through their early post-op period. Many of those patients are feeling better. Do you counsel at all about the potential for recurrence or other problems that can happen down the line?
I think the recurrence is something that you have to let the patient know is a rare possibility. That's why it's important to do the surgery technically well. It's one of the reasons that I push people to do the surgery open, as long as they don't have a strong opposition to it. I do think it's easier to ensure that you've done a complete release and you're looking at the nerve. But certainly it is a possibility, and you do see people every once in a while coming to the office with complaints of recurrence after surgery 15, 20 years ago. It is a rare, but it's a documented problem, and oftentimes it does require a more extensive approach, like you mentioned, a bigger incision, and potentially even adjunctive procedures like covering the nerve with another tissue, another substance, fat grafting. And these are all things that are rare, but rare problems sometimes demand rare interventions. There are other places which are very rare, but definitely are out there. Like you mentioned, the nerve can be pinched in the forearm. It can be pinched, around the elbow. And these are all things that are tough to diagnose and tough to pick up based upon the patient's history and examination. So that's why it's important to see a hand surgeon when you have these sorts of problems. And it's up to the hand surgeon to carefully listen to the patient's complaints and carefully examine them. And for the most part, carpal tunnel syndrome is a common problem, and it's common as we get older, and it's associated with other medical problems. And most of the time, it's well treated by releasing the ligament, or sometimes conservative treatments. But there are rare diagnoses, and those advanced tests can help eliminate or rule in some other causes. And you certainly don't want to miss the patient that has another nerve that's compressed and is, you're taken to the operating room. You don't want to do surgery on them, and it's not going to fix their problem.
Yeah, clearly I've seen many patients in the past who have very carpal tunnel-like symptoms. It's not a perfect story. It's usually not a perfect physical exam, and it's the form fruit of multiple sclerosis. And you need to get the neurologist involved. And see, I think although we see a lot of it, and it's a common problem, you still have to maintain a high level of clinical suspicion for other potential problems that can be there. And it actually goes back to something you were mentioning and the comorbidities that you can see, Ryan, with carpal tunnel syndrome. There are a couple that are fairly common, and every once in a while we could actually make a diagnosis that somebody didn't realize they had based on having an acute presentation of carpal tunnel. What are some of the things that you guys have seen? Chris, why don't you go in terms of comorbidities that you'll see frequently with carpal tunnel syndrome?
Sure. So one of the most common things you see is unfortunately in pregnant women, where you do get fluid shifts and things of that nature. And it is very commonly treated conservatively, which is the good news. Is once women deliver the child, this does typically go away, but that's a very common one. Very common you see in patients with diabetes. And the question is it more diabetic neuropathy versus carpal tunnel syndrome? And you have to help differentiate with that. And that's where one of those nerve studies can come into play, because it can tell you if there's slowing of all the nerves, which is more common with diabetic when you have diabetic neuropathy across all of the nerves affected, versus carpal tunnel where there's compressive neuropathies. So, and sometimes you can have both. And so they both need to be addressed. There's very common things with thyroid problems, alcohol can also do that with alcoholism. Rheumatoid arthritis and other inflammatory joint problems are very common, and very frequently I'll pick up a few a year just by saying, if you have carpal tunnel, you also find some tendon issues with them, and then you ask them a little bit more further questioning. I had some tendonitis in my shoulder and both my elbows are hurting too. It's not pain radiating up from carpal tunnel, but it's actually bilateral tennis elbow going on as well. And you lead further into things, and I'll send some people for inflammatory workups and find that they do have rheumatoid arthritis or lupus or something along those lines that gets missed. And so, some of the times these simple things can lead to much bigger, problematic pictures, unfortunately. So
certainly some of those diagnoses are way more beneficial to catch earlier rather than later, because of the treatment programs for them are better instituted the earlier you get to them than later, for sure. Ryan, anything to add to that?
I would, I think those are all great points. I certainly think that people with diabetes they get a more vicious form of carpal tunnel and trigger finger, and they are much less likely to respond well to steroid injections. So, it's important to just counsel those patients that you're gonna, you may need surgery, and just kind of get their get them exposed to the concept earlier. I would add that gout is something that you can actually see the deposits of those calcium, or not calcium, but uric acid crystals, and also pseudo gout, which is a calcium deposition problem. You can see not just nerve problems from the deposition, but also tendon problems. And of course, infection is a rare, but it is a possible cause of infection, and also ganglion cysts. These are all rare, but things that we see every once in a while in a patient that didn't know that they had a problem. While performing the surgery, you make the diagnosis. But realistically, sorry.
I was going to say, I think all of those points both of you make are excellent points. And again, although we see a lot of carpal tunnel syndrome and it's a relatively simple problem, there can be great complexities. Then, requiring the need to have somebody that really knows what they're doing take a look at that and make sure that they're not missing anything. Again, that stone being left unturned can be your downfall.
Right. I think, the goal, as you're saying, alluding to there, is it's not just the mechanic to solve the problem, is you want the doctor to actually take a look at the patient and figure it all out. So I think that's a good point. And I think one of the things in discussing with the diabetics as well is just cautioning them as well as with the steroid injections to monitor their blood sugars and things like that, which is obviously important after the injection, because it can affect the glucose levels. And so since we are talking about other medical issues and steroid shots at the same time, for people who are watching this and you are diabetic, you do need to be mindful of that when you do go for your steroid injections. If you're getting it either here or another joint, wherever it may be, that you just got to be careful of that.
Yeah, that's a really good point. Ryan, you also made a good point about patients that have some of these comorbidities being much more recalcitrant or much more difficult to treat over the long haul, and therefore more commonly needing to have more advanced treatment, such as the surgical release. How often do you guys experience somebody who has symptoms that are only transient and they go away without the need for surgical intervention?
Well, yours truly. I've had this when as an example, first moved into a house and I painted my house and I had horrible carpal tunnel symptoms. And, I've been there. I know how it feels. It's not fun. And I will never paint again from that standpoint on, because I don't really feel like going through that again. So I totally understand it. It can be transient. It can go away. So that is the good news once you treat it properly. So it's just trying to make sure you get on it early. And a lot of people, unfortunately, do ignore it for an extended period of time without treatment. So I do think, something like this is beneficial because at least it can get some of those early treatments out there. Patients can start doing it on their own if they don't even feel like coming in because they don't have the time, because I never saw any of my partners either. So I totally understand that. And you just got to get the treatment started as soon as possible so that you don't fall into the chronic category.
Yeah, I think it's nice for patients to hear that they're not doomed as soon as they start to feel some pins and needles, that it's a fait accompli, that they're going to need to have surgery, that there is successful treatment with conservative modalities in many of the cases, but certainly not all of them.
Sure.
Well, gentlemen, I think that pretty much wraps things up. We've covered the carpal tunnel pretty well. We've touched on some other issues that are related to carpal tunnel, and I think that should answer a lot of questions. I'd really like to thank Christopher Doumas and Ryan Coyle for being with us here tonight and answering some pretty pointed questions and giving us their expert opinion on what it's like to have and treat and manage carpal tunnel syndrome.